Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Faryal Michaud. She's a palliative care physician, and she wrote the Kevin MD article, The Importance of Holding Space. Faryal, welcome to the show.
So happy to be here, Kevin. It's lovely to meet you in person like this.
So we'll get into your article in a little bit, but first off, can you share your story and your journey to where you are today?
Oh, I'd be glad to. So I started by being an internal medicine trained physician. Initially, I was an academic hospitalist, but then I was working as a private hospitalist for 10 years. And during those years of practicing as an inpatient hospitalist, I just realized that there's a huge empty space about having important conversations with inpatient clients that would come and go. And I started getting really interested in palliative care. And by the time I had finished my internal medicine training, palliative care subspecialty did not exist. So I had to go back and do extra training afterwards. So then there was a period of time that I did palliative care and then hospital medicine. And then when we got really busy, then I shifted entirely to inpatient palliative care, which is what I've been doing for the past 6 years now.
Now, tell me how the pandemic has affected your work as a palliative care physician.
That's a great question, and I'm so glad you bring this up. I think that obviously pandemic has affected every aspect of medicine, but I personally think that our service line has been overwhelmed because there's a huge need of having early goal of care conversations with patients that we can see that they may head that direction, and maybe families and patients themselves do not want to have that prolonged protracted course. But what's been hardest for me is because it's all virtual. We have no visitation policy unless there is absolute end of life. So when someone's actively dying. All of these conversations that before would happen with patient and family at bedside, and they would really rely on family support to make big, decisions. They're all being done via, Zoom. It's not really Zoom, it's kind of team meetings. And families are really struggling because their loved ones are alone in the hospital, and patients are struggling because there's no family support. And so these people are in a hospital for a very long time. So that's becoming very difficult, and patients are, dying alone. Mm-hmm. They have no resource. And also our own, we tried to, in the beginning, because we were trying to limit our PPE use, we only would go in if we had to. So our team is multidisciplinary, Kevin. So there's a physician, there's a chaplain, there's a social worker and a nurse. And usually we would all go in together with our own chair, sit around, talk. Now there's only one person that goes in, and the rest of the group is actually in a separate room. So we can't read the patients. Mm-hmm. So I think our practice has changed. We are busier, but we are really practicing in silos. And I really don't think that patients are getting the best care, but that's the reality of our time right now.
Now, when you talk to patients and their families about palliative care issues in a virtual setting, what are some tips to maintain that connection as best you can?
That's wonderful. So one thing that we actually do, so for example, I could be present at bedside if there's patient symptomatic, or has issues that need to be addressed, or a social worker. So what we do, we describe to the family, if the family cannot have, visual way of looking at their loved ones, because not everyone, we have different, very multicultural area in Hawaii, and not everyone can manage audio visual. So we describe the patient. If we say something and the patient smiles, we tell the family, okay, he's smiling right mm-hmm. now, or he was very touched and he's happy right now. Or if he's sad and he's crying, we'll say he's crying right now. I think painting a picture would allow family to be there. And then we also check in with people when they're quiet. So we will call in the son, who may say nothing at all, mm-hmm. because obviously they may be on mute, but also they may be crying. You don't know what's happening. So actually actively calling in and inviting them to the invitation saying, John, you heard what we said. What do you think about all that? So constantly bringing everybody in and, doing the best that we can and describing the patient to their loved ones so they feel like they're there. It's very powerful.
So let's transition into your Kevin MD article, The Importance of Holding Space. Now, for those who haven't read your article, can you walk my audience through it and share the story of why you decided to write it?
Yeah, thank you so much. And I felt so, inspired to share this. I've been reading your articles for many, many
Oh,
years.
thank you.
And yeah, so I wanted to say, so, one thing that we do in palliative care, and I've heard people reference to it, and I don't really think people understand it very well, is the whole idea of, again, holding space. You hear people, we're going to hold space for them. It's almost like non-action. And I actively meditate, and that's something that I really love. And I started thinking about the actual act of holding space, where you really are non-judgmentally sitting
Mhm.
there for the patient and trying to take whatever that comes to you, whether it could be sadness, madness, anger, denial, and just really hold that space for them and really understand the therapeutic value of that. The term attending,
Mhm.
a physician being an attending, really it means attending to the patient and not necessarily give them, do lab draws and give medication and this and that. And sometimes our job is that therapeutic presence. And I just realized the more residents I had, the more people that would come and rotate with me, new, physicians, I just realized this is not very well taught. So I thought, what if I put it in words? And then as I was doing that, I sort of felt like, it's very similar to meditation as well, where you are holding space for different thoughts, right? You could be angry and just realize, okay, I'm angry and I'm just going to let this slide. And I think that same interaction comes, in focus when you're dealing with patients. So I actually have, Kevin, I have a support group for physicians, and I initially had written this particular holding space article, a version of it, to that group, and it was very, very positively,
Yeah.
people were so much, having response saying this is wonderful. And then someone shared, it would be wonderful if you could share it with a larger audience, and I can't think of a larger audience than your audience, so there it is.
Thank you. Wonderful. And it clearly resonated because that article got 2,000 shares on social media. So I think you clearly struck a chord. Now, we in primary care, of course, we talk about palliative care issues as well. And you're right, we don't have a lot of training in this. So when you teach your residents and your clinicians about holding space, so how do you go about teaching that to us?
An analogy I always say is that, similar to palliative care consultation, and that is like, if I was going to a palliative care consultation and my job was going to be to share a difficult decision or a poor diagnosis, just a bad news, the way we approach that is that we imagine that we go into the patient's room and we open that door. We open the door to the patient's room, and then we share what we have to share, whatever that is. And I teach extensively how to do that. But after you share that communication, and the example I used was, telling someone they have stage 4, metastatic pancreatic cancer, that there's no treatment available, it's non-surgical. When you share that information, as physicians, we're such fixers. There's such an urgency to
Hmm.
say, as soon as we see someone crying, it can say, oh, but there's new studies that came out, or, oh, there's new, there is, we want to rescue patients.
Yeah.
But I think what I want to say, hold space, would be to open that door and then just wait for what's coming to you. It may very well be that, patients may run to you because, like, they would say, I knew something was up, and that you just kind of respond to where they're at. And where they're at may be to slam that door in your face, and it's important not to take it personally. And again, not to rescue. If they need to shut you down, that's their job. You're holding space for all array of emotions. And sometimes, my husband is a radiation oncologist, so I actually teach this to him as well. And, he says, like, how long do you wait, or what's the pause? And I always say, you stop after you share whatever you have to share, and then you let them say something. So if you don't know how long and it feels ridiculously long when you haven't done this for many times, even 2 minutes sounds like an eternity. But when you just tell yourself, I'm going to wait to see what they have to say. And then whatever they say, whether it's anger, whether it's frustration and denial, you hold space for that too. Meaning, I see that, you attend to whatever feeling that is. You don't have to do anything. And even not doing anything, you're doing plenty a lot.
That's wonderful advice. We're talking to Faryal Michaud. She's a palliative care physician. She wrote the Kevin MD article, The Importance of Holding Space. Faryal, so in primary care, we're overwhelmed with a zillion checklists that we have to do, and we're all pressed for time. Yet we know that discussing advanced directives and palliative care issues is certainly critical for every patient. Now, can you share your approach on how to bring up these issues in a typical primary care visit?
Yeah, so I think it's what's very important is that I think a lot of times physicians feel awkward because they feel like if they go that route, they're taking the hope away, that it's going to be a difficult conversation. And I think if you come from a place of worry, so say your patient has congestive heart failure, has been in and out of the hospital for 15 times the past year. And how do as a primary care physician, how do you have a conversation in a well setting that doesn't take an hour of your time? And this is what I will say. I will say that here's the conversation would go. That, like, for example, hey Marie, I heard that you were in the hospital and you were very sick. Like, tell me about that. So let them give you a little bit, and you can listen for what they have to say. And then you start by saying, I really wish that whatever's going on with you, say congestive heart failure, was going to miraculously go away. But I worry that at this stage, nothing we do is going to actually change the trajectory of your disease.
Mm-hmm.
And I wonder if we should talk about what would we do if this happens again. This sentence, wish, worry, wonder, and I teach this to my residents, and I actually have an episode like that. How do you use that to talk to patients? It's going to get you out of any difficult conversation, and it's going to be a quick way to wrap your mind around a difficult thing, and you align yourself with the patient. And when you worry, they worry. When you wonder, you're sharing your prognosis and recommendation.
My final question, what is your take-home message that you want to leave with the Kevin MD audience?
I want to ask everybody that if you feel like patient's been struck by a serious illness and you do have a palliative care service on your, hospital or in your institution, please use us, and in a way that palliative care does not mean giving up hope. I would like us to be involved upstream. I want patients to make decisions knowing what their options are, and we empower patients. We don't take the hope away. So I just want to encourage everyone to look at us as a glimmer of hope, and not somebody who comes in and takes patients' hope away.
I understand you started a podcast earlier this year. Can you talk a little bit about that and how people can reach you?
Absolutely. So, I started a podcast during COVID because I just felt like there was a lot of physicians struggling with all this, not enough palliative care physicians going around. And I also want people to live their bucket list now. I don't want you to wait until you get sick to say, okay, now I have only 6 months. How can I jam everything I wanted to? So living intentionally is what I really try to strive myself, and also pass that to people. So I started a podcast called Write Your Last Chapter. And this podcast is divided into a guest show. I have Palliative Pearls, which I share, which is educational, which physicians and patients alike, as well as then I will have what we call Talk Story, which is sharing life stories that you can actually take and somehow allow that to be part of your guiding light of how to live your life intentionally with Bucket List Now.
Well, thank you again for sharing your insight, and thanks again for being on the show.
Thank you, Kevin.